Yes, I should also say that I don't have any affiliation with Joint Commission or CMS. All of this is just from reviewing their standards and their conditions of participation from CMS. So everything is kind of how we've interpreted it and from experience through survey. So happy to take any questions at any point. Like I said, I hope this isn't going to be as boring as our usual webinars since it's not a clinical topic. All right. So you might be familiar that the antibiotic stewardship program requirements changed as of January of last year. Joint Commission either edited some of their EPs or added some new ones. There's 12 that were added. And then the conditions of participation, I'll refer to them as COPs from CMS. There's also 9 updates there. And just a summary of antimicrobial stewardship requirements. As you can see, whether you're in an acute care hospital, critical access hospital, or just AmCare, there are requirements from Joint Commission, CMS, and CDC. Now, the requirements might look a little bit different, but in general, there are definitely requirements and mandates to have an antimicrobial stewardship program. I'm going to start going over the Joint Commission requirements. I have put it where if there is a CMS COP that is in line or similar to a Joint Commission one, I put them kind of back to back just to avoid repeating and because we would meet the same metric. If a Joint Commission requirement is new, I've made sure to put new in parentheses. Again, if it's revised, I also put that just so you know. And so if you've done a past survey or if you've done a survey recently, so you know which one, I'm sorry, if you have an upcoming survey recently, then you know which ones maybe we'll need to prepare for a little bit differently. I won't read them all word for word, again, just for lack of time, and so we can get through the important parts. So the Joint Commission EP10 is a new one, and this one asks that each hospital allocates financial resources for staffing and information technology to support the antibiotic stewardship team. If we are asked about this in survey, you know, our MD stewardship team is available 24/7 with our physicians and pharmacy team to assist with all of antimicrobial stewardship questions. EP11 is revised. So this one asks that each hospital appoint a physician and or pharmacist, it does not need to be both, who is qualified through education, training, or experience as a leader of the antibiotic stewardship program. And so what this means is that each site basically needs to have a letter that is approved by your hospital board that says, here's the pharmacist that's in charge of the program, or here's the physician that's in charge of the program. Obviously, with that, you do have the MD stewardship team to add to your letter as leaders as well for your stewardship team. It is also good to have a stewardship charter at each facility. So this could look like a policy or just a charter that's updated yearly. And our team is definitely happy to assist if we need to create one based on this revised regulation. Like I said, if a COP from CMS is similar to Joint Commission, I kind of put them back to back. So this is very much saying that each hospital should have a stewardship program. However, they do not say how much you need in staff. They don't say how many FTEs or how many hours dedicated to stewardship. But again, you can speak to MD stewardship being available 24/7 and that whoever your hospital dedicated staff to doing stewardship work should also be called out. Again, it doesn't matter how much of their FTE is for stewardship as long as they are working in stewardship. And this is the same as the Joint Commission EP10. Right. This CMS COP is also very similar, just making sure that that person, whether pharmacist or physician, is appointed in like more of a formal way than it used to be. So usually hospitals will have this like a board delegation letter that says our hospital has approved this person to lead our stewardship. and then with the MD stewardship team support. All right, EP 12 is not a new one. However, it is revised, and I broke it up into these four components so it's easier to speak to. The stewardship program requirement is to develop and implement a hospital-wide program, like we have discussed, based off of IDSA and CDC guidelines, which we have. Number 2 talks about documenting antimicrobial stewardship activities, including any new or sustained improvements. So you can either document interventions, like if you have an EHR like Epic that has IVents where you could document them. If you use the MD Stewardship Zoho document to document interventions, that's appropriate. Basically any kind of tool where you can track different types of stewardship interventions. And then number 3 talks about communicating and collaborating with different people in the hospital. So different groups such as med staff, nursing, pharmacy, infection prevention, obviously quality. So with this, we just need to make sure that at your specific facility, there is some kind of ASP reporting. Now it doesn't matter the cadence, whether you report quarterly or monthly, but just ensuring that the right stakeholders are seeing these type of interventions. So if you do document in the MD Stewardship Zoho tool, those reports are run for you and you can present those, or if you have your own kind of tracking metrics. So making sure to do that, and when we have a survey, to be able to provide that if asked. And then number 4 is providing competency-based training and education for all staff, including med staff, on antibiotic stewardship guidelines. So these webinars count for that. We have several other webinars, educational series on the MD Stewardship website to help us meet this metric. And those could also be tracked if you're asked, like who attended that by your survey. All right, this is CMS now, a very similar COP to what we've just been discussing with the Joint Commission EPs. So ensuring we have a leader at each site. I know I keep saying that. And then this one wants to make sure that the leaders of your stewardship program are qualified. So this is the physicians and the pharmacists. So if we are talking about the MD stewardship team, for example, our physicians are board certified, either by the American Board of Internal Medicine or infectious disease or both. And same with our pharmacists, either board certified in ID and holding SIDP, ASP certifications as well, to have that qualification to lead the program. And if anyone, I'll speak for pharmacists, if any of the pharmacists you work with or yourself are interested in gaining any of these certifications, then certainly there's requirements for BCIDP that ACCP outlines, or for the SIDP certificates, just a certification program, and it's kind of a one and done. And I've done it, and I obviously very much enjoyed it. And then with that, meeting qualifications, but maintaining qualifications. So CMS wants to make sure that we are completing CE that is relevant to infectious disease or antimicrobial stewardship specifically. So they outline some CE available from SHE or IDSA or SIDP, but I've actually confirmed this with them, and those are not all inclusive. So any kind of CE you're doing that would be related to ID or ASP would be appropriate. So attending a national conference, attending some MD stewardship webinars that are ID specific, anything like that would be appropriate. All right, this CMS COP also wants to make sure that our antibiotic stewardship program has policies governing the optimal use of antibiotics. So I'll use some examples here. If you have restriction criteria for some of your antibiotics that are approved by a committee such as P&T, that would be appropriate, or outlining any interdisciplinary work For example, if your microbiology team develops a hospital-specific antibiogram that is appropriate to meet the COP. And again, always outlining how the MD stewardship team can support you with all of these to meet the COP. Back to Joint Commission. Again, I'm just flipping back and forth. If they align, I'm putting them back to back just because it's repetitive between the two. And I know some of you have Joint Commission, some of you have CMS, so that's why I wanted to group them together just to make it a little bit easier to remember. Okay, so this EP says that the hospital has to have a multidisciplinary committee that oversees the antibiotic stewardship team. I want to outline in the first note that it says the committee may be composed of representatives from med staff, pharmacy, infection prevention, nursing, micro, IT, and quality. And in note 2, it says that this participation may occur on-site or remotely. So like within our group that supports your hospital remotely would still be okay. If you don't have a standalone stewardship committee, that's okay. As long as it's added to an existing committee. For example, if you have a standing P&T committee and you are presenting your data there, that could count, or if it's part of quality, group, or infection prevention. It can be a standalone stewardship team where you only discuss stewardship, or it could just be part of another committee. And as you can see, there's a trend here in talking about antibiotic stewardship now, not just being pharmacy and physicians, but including all of the important groups for our multidisciplinary work. Again, so med staff, nursing, pharmacy, quality, infection prevention, obviously microbiology, just making sure we work with everybody instead of just, you know, in the beginning when it was a lot of just pharmacy and working with our physician support. EP15 talks about documenting the use of evidence-based or the appropriate use basically of antibiotics based on evidence-based guidelines in all departments and services of the hospital. This could be difficult to track if you're manually tracking every antibiotic that's ordered within the appropriate indication. But if you have updated order sets and you know that the only way to order these antibiotics is through an order set, for example, like pneumonia or UTI, then we know that the use of those antibiotics is evidence-based. Also, if you have restriction criteria, like we previously discussed, then you know, for example, every time a carbapenem is ordered, it's meeting these specific restriction criteria, so it would be within appropriate evidence-based use. Just a few examples to help with this EP. Okay, I'm going to spend a little bit of time on this because there are new requirements with documenting and reporting through NHSN. So this EP is revised. NHSN is the National Healthcare Safety Network. This is through the CDC. It's monitoring antimicrobial use and resistance, obviously for all of the resistance threats we are having across the country. So if you do participate in NHSN, that meets a lot of requirements for tracking and reporting, but it takes a lot, obviously, to be set up to submit to NHSN, what you need to submit. So I wanted to take just a few slides here to talk about NHSN specifically, again, because these requirements are very new. And I want to start with some of the NHSN definitions. For example, the first one is days of therapy, or DOT. This is measured in antimicrobial days per 1,000 days present. An antimicrobial day is defined as any amount of a specific antimicrobial administered in a day to a patient. And the days present, it becomes an aggregate number of patients in a location anytime during the day, during a calendar month. I know, very easy to understand, not. So these calculations are very cumbersome. They are not to be done manually. If you have the software to do that, that could be set up to calculate. But a lot of people say, like, how do I know my days of therapy is appropriate? For example, say you're tracking your cepepime and your days of therapy is like 89. You're like, is this good? Is this bad? So because of that, there is something called the SAR, which is the standardized risk adjusted metric for antibiotic use. And this basically compares observed to predicted days of antimicrobial use. And it's a quantitative tool to help you make comparisons across different facilities. The equation is the observed antimicrobial days over the predicted antimicrobial days. Again, this is not something that's manually calculated. The softwares that calculate it use like barcode scanning, for example, to calculate the antibiotic days. But when you use a SAR versus a days of therapy, it is basically benchmarked to a number 1. So if your SAR is greater than 1, then that indicates greater than expected usage of antimicrobials. If it's less than 1, then that indicates lower than expected usage. And if it's equal to 1, then that's basically what's expected. But I know it benchmarks to 1, but it's not a true measure of appropriate antibiotic use. It could help you like initially identify a site, or if your hospital is continuously over 1, then maybe like evaluating trends, prescribing, order sets, things like that. But it doesn't necessarily mean just because you're over 1 or less than 1 that you're doing good or bad. It just helps to benchmark across other facilities. And the SAR uses a p-value and a 95% confidence interval, basically to calculate if these variances are statistically significant when there's change. If you do not currently have an EHR that can support with NHSN submission, again, this has become required, at least starting with AU, antibiotic use before AR, which is resistance, and Bayer's work with the microbiology team. There are some grants in some states that would either pay for the software or anything that could help your site get set up. I have specifically here for Nebraska, because there is a grant and there is a pharmacist that could help your site if you are in that state. But again, since it's required, a lot of states are working on grants to help smaller hospitals or hospitals who might not have the EHR support to be able to do it. I did reach out to NHSN to see if they can provide us with more help or help us get started. And they basically this week are providing training. So a lot of their videos are, you know, if you're a large facility or critical access or rural, any type of facility that has electronic health records would qualify for submission. So I just added this link because getting the training initially or, you know, directly from NHSN is better than any way I could be able to understand and summarize it for all of us. I also included on here a ton of links. There are so many resources for NHSN. It's a little bit overwhelming, but I picked out some of the ones that could help in starting. The guides, some FAQs, and I have actually used this NHSN question link, their email link, and they are pretty responsive. So if you have a specific question, like you started at your site or something's happening, then they are very quick to respond and give resources or link you to something that might be helpful. That is it for my NHSN tangent. I know this is not the most exciting. I will go back to the rest of the regulatory requirements, but just wanted to make sure we took some time out for that last CMS COP, since, again, NHSN reporting is now mandatory. All right, and this is very similar to what we were talking about before jumping to NHSN. Basically ensuring that our program for stewardship meets CDC core elements and is in line with the IDSA guidelines, which is something we make sure before we start the program with any hospital. And then also talking about creating order sets based on updated treatment guidelines for appropriate antibiotic use. Order sets just being something very easy to track, and then knowing that your physicians or providers are clicking on an antibiotic from an order set that's been reviewed, so it starts the process off correctly. And then one important thing is, just because we started the antibiotic correctly in the beginning based off of our differential diagnosis, it is very important and imperative to review this within 48 or 72 hours. The timeouts per the CDC requirements have changed. So there's no specific timing, but the 48 to 72 is just a ballpark, because by then you probably would have more culture results back. You would know a little bit more about if the procal is trending down or how the patient is doing. So it just helps better streamline the antibiotics and making sure what we chose empirically is still appropriate, or if we're able to streamline. Again, those times are just a ballpark. The CDC requirements are no longer as strict as they were before for a timeout. I promise I'm almost done putting you to sleep with this, but I think it's very important, and I will save some time for us to talk about any questions or thoughts you might have specific to this. This EP is new. However, this recommendation is not new to stewardship at all. It is the implementation of either pre-authorization or prospective audit and feedback. Pre-authorization is basically if you have a restricted antibiotic that nobody is able to order it without discussion with the stewardship team or pharmacy. This is the least favorable recommendation per the guidelines, just because sometimes it can delay care unless maybe you allow a first dose and then you review the antibiotic. What is a more favorable recommendation is the prospective audit and feedback. So a medication is ordered and then we review it and we ensure it's appropriate, right drug, right route, all of that, and then streamline as needed. So again, these are not new recommendations for stewardship, but the EP from Joint Commission is new. This is also new. The antibiotic stewardship program implements at least 2 guidelines to improve antibiotic use. I know I've been talking about this. So guidelines, you can have pathways or order sets. This example just calls out some of the most common. This is not all inclusive. So CAP, UTI, skin and soft tissue, C. diff, CDI. So if you currently have pathways or order sets that are one of these examples or different ones, and you know they're updated, then you meet this new requirement. If you have some and they are outdated, then that's something maybe we can work on reviewing or updating. And also on our MD Stewardship website, we do have some examples if you're like, I don't know where to get started, or like what's an example of a pathway or an order set. Definitely just an example, not the only way to do it, but we have some for UTI, CDI, pneumonia, just to help you get kind of an idea. And it looks different based on what EHR you have and how you want to build it. And then with that, if you do have these pathways or these order sets, how do you evaluate adherence to these? So you can either measure at the group level, so like like your ICU is always using meds appropriately, or you can like drill down to like specific clinicians. So these prescribers always use Piptazo appropriately, for example. But you can also track things that are more general in the hospital. Are we using the appropriate treatment for CDI in general? And we're going to follow that for the year. Like, are we using vancomycin, PO, or fidaxomicin and not metronidazole? Making sure we are following the newer guidelines. Or if you have an MRSA or MSSA bacteremia, are we using appropriate therapy there? I'm just calling out some examples that you can use like to track. Or surgical prophylaxis. A lot of their recommendations are just to use cefazolin. So tracking the timing of that, if cefazolin was appropriate, could be an easier one to track and report. And I mentioned this before, but if you are putting in interventions in the Zoho document, that is also collected and sent to you, so you can use that for reporting. I get a lot of questions and like, what should I report? Like, I know these last two EPs talk about collecting data and reporting it, but what kinds of things could we report? So I just picked out a few examples. Again, not all inclusive, but thinking as a pharmacist, like what things could I collect that would be relatively easy. Reduction maybe in vancomycin use or reduction in C. diff rates. And this could be in collaboration with the infection prevention team. And you could track the drugs based off of drug cost, which I know is not always the best way to track usage because drug costs change and sometimes we have shortages and we have to switch meds. But you could also trend IV to PO. So for example, if you're tracking over time and you pick out just a couple of medications like that are maybe 100% bioavailable, so it's a very easy switch, metronidazole, a fluoroquinolone, or azithro, and say like this year I'm just going to track this to lessen cost. You know, switching to a PO drug is more than just the drug cost. You know, track this over time and see, and then report on that. Or if you just want to track and report on interventions, so you could say, you know, over time, every time the ASP team called, we had dose modification interventions to ensure the patient was on the appropriate dose. All of these reporting metrics are appropriate. Again, these are just examples. You don't only have to track IV to PO. You don't only have to track reduction of broad spectrum usage or drug costs, but anything that is tracked within your facility would be appropriate for the last two EPs we discussed. Okay, and this is a little bit of a repeat, but CMS also wants to make sure we have internal coordination among all components responsible for the antibiotic stewardship team. So again, talking about working with a multidisciplinary group, whether it's IP infection prevention to discuss CDI rates, or with the quality team, anything like that. And then documenting everything and reporting it. So if you say we have limited our broad spectrum antibiotic use, and here's our antibiogram, and presenting that, and that is certainly something we can show on a survey, as long as you have your own facility antibiogram. And will not, EP21 is revised, but it meets the same COP as above. Okay, I know I've flown through those, but there's so many COPs and so many EPs for Joint Commission. So if you're like, I have a survey coming up, these are all new to me, where should I start? For me, what I found is starting with a gap analysis tool is the most helpful. So if you pick out like, here's all the Joint Commission EPs, here's all the CMS COPs, depending on which one you're surveyed by or both, and where am I currently, and maybe what do I need? So you can say, like one example is I lack any updated order sets. I'm going to focus on that before my next survey. Or I don't have an updated stewardship charter with my name on it if I'm the lead with MD stewardship. Just starting there so you can see like big picture, looking at it as a whole, where am I, and then what do I need to be? I found this personally to be helpful. Or you can do it bigger, and you know your site meets CDC core elements. You know that, you know we're in line with the IDSA guidelines. So at least you're comfortable speaking to those two, and then now adding on whether it's CMS or Joint Commission requirements to be able to speak to it. For me, when I'm surveyed, I want to make sure like everything, I have everything like packaged up and I can speak to it, because sometimes I could get anxious if they're like, what do you do for this? And I'm like, oh my gosh, we do a million things. But when they're asking you, you could forget. That's why I like to put it like this, certainly just my opinion and just sharing something that's worked for me. And then when your surveyor is here, like I was talking about, The most important thing is starting explaining how you actually have a robust program. We have daily prospective audit and feedback. We have 24/7 support from physicians and pharmacists that are specifically trained in stewardship. Our program is built off of CDC guidelines as well as IDSA recommendations. We have physician champions and pharmacy. And again, if you work with a multidisciplinary infection prevention or microbiology, make sure to bring that in. And then provide documentation. So you have Zoho reports for interventions, or you have a new pathway or guideline that was updated. Being able to show those to a surveyor is really important to outline the program. I promise to have time for questions. So thank you for putting up with me going really fast through those regulations. Again, a lot of this is our interpretation from CMS and Joint Commission. I am not a surveyor and have never been. So just from reading it and some of the experiences we've had. I hope this is helpful. I'm definitely happy to work with each of you individually. If you're like, there's just one EP I want to work on, or something from CMS that I might not know how to answer, because a lot of it is just site specific. I'm going to stop talking and see if there's any questions. Okay, I see a request to share the slides. Yes, we will have the slides and the recording as well, if that would be helpful. Thank you, Sarah. Thank you to everyone for being my mini cheerleaders on my phone and on chat. I hope this is helpful. Again, I know sometimes this isn't really exciting, but this is important, and happy to work with you individually if that would be more helpful. Okay, thank you to everyone. I just see a question about if the CDC has documents specifically regarding how to use the SAR data. Kara, there is a like a SAR guide from CDC. It's like 72 pages or something. It kind of just talks about like different trends. It gives examples. So if you are less than one, here is an intervention that was put into place, and then here's how it evaluated. So I did use that link in the slides, but if that's something you are looking for, I'm happy to discuss that more and just show it to you. Awesome. Well, thank you again, everybody. Have a great rest of your day.